Hello everyone. Sharing one minimally edited video of laparoscopic TAPP repair for a case of right-sided direct inguinal hernia with enterosil in a 73-year-old lady. So placing standard ports for right-sided TAPP repair. So camera was 10 millimeter camera supraumbilical camera port 1 inch above the umbilicus, and right and left and working port with 5 millimeter. So after going inside, you can see the inferior epigastric vessel are clearly visible, and just by the medial side of the inferior epigastric vessel, the small bowel, the ileal loops were going inside. So after reduction of the hernial content, check the bowel viability, it was okay. And then the hernial defect can be clearly seen, and there is a little bit of scarring which is suggestive of prolonged hernial presence of that hernia. So I've started marking the peritoneal incision at least 5 centimeter proximal to the hernial defect area, proximal part of the defect, and started raising the peritoneal flap, not just the peritoneum but the fascia transversally. You can see the transparent layer of fascia transversalis taken into the flap, so that the flap becomes a bit thicker. And she is a thin lady, only 36 kilo of weight, BMI was around 19. So there was very less amount of preperitoneal fat, so there is a chance that flap may tear during the process of dissection. So staying in between the layer of fascia transversalis, I started raising the flap further, and the adequate incision was given, peritoneal incision was given, and gradually progressing, safeguarding the inferior epigastric vessel. The inferior epigastric vessel should lie above, and first thing is to create the lateral space of Bogros, and then the medial space of Regia, so that we can dissect all around the hernial sac first, and then finally target the sac. So you can see I'm just following the loose areolar tissue plane, and just the yellowish fat should lie above, go along with the muscle. And I'm going just below that, there is a loose areolar tissue plane, that is the area of dissection, that completely avascular plane. There will be no large vessels, maybe small perforators which can be easily cauterized with monopolar energy. Adequate traction with your left hand instrument is absolutely essential, because once you give adequate left hand traction, you will be able to see the tissue plane that has to be followed, and then you can dissect in that plane. So you can see the clearly there is a dulux fat which is actually the parietal fat, and which should lie over the lateral abdominal wall muscles, so that it will protect the psoas major muscle and the overlying nerves, and that should not be disturbed. And now gradually, after dissecting and creating medial and lateral space, now I am trying to dissect the reduce the hernial sac. So you can see gradual progression with my traction and the pulling the peritoneum, that is the hernial sac, gradually being reduced inside the intra-abdominal portion. And you can see there's small perforators which are actually coming from the inferior epigastric vessel, going transversely above the Cooper's ligament, that has been safeguarded. And now the bony Cooper's ligament can be easily seen, and then further dissection of the peritoneal fold brought down, and this is the round ligament which is identified and divided close to the ring. And the further dissection, further mobilization of the peritoneum is done. And you can see the structure medially, the important structure, the external iliac artery and vein medially, and then further Cooper's ligament, and further mobilization of the peritoneal fold is done laterally. So the idea is to create at least 6 to 7 centimeter area all around the defect, and for that adequate mobilization of the peritoneal fold should be done. And you can see I'm keeping the dulux fat over the muscle, and that will protect the nerves, underlying nerves, and that should not be disturbed. And medial mobilization is done till we see the obturator nerve, that it can be seen now. This is the obturator nerve, and then further near the obturator foramen we can see the corona motis, the accessory obturator vessels can be seen. The space of Regius has been created, and till the symphysis pubis, till we cross the midline. and then little bit of further dissection on the lateral aspect, and that will almost complete the dissection. And now I have placed a 12 by 15 centimeter medium weight fat polypropylene mesh that I generally use, and then the complete placement of the mesh is been shown in this video. So here you can see the if there is adequate space being created, then there will be no problem initially. After placing the mesh, it seems the mesh is a little bigger than the space created, but I have to make a little bit of adjustment here and there so that I can place the mesh nicely. So there should not be any compromise with the mesh size and the area of dissection that has been done. And the most important thing is lower border of the mesh should lie flat, and it should be above the peritoneal reflection. So you can see I'm trying to see the peritoneal reflection, what is there. So you can see the peritoneal reflection is there, and I have just kept the mesh just above it so that no part of the peritoneal should go behind the peritoneal reflection that can be the potential cause of recurrence of the hernia. So I'm just trying to adjust the upper border of the mesh now, so that I can place the mesh nice and flat. So for that, I felt a little bit of lateral dissection should be done here. So that has been done. And then for the space creation, so medially mesh should be placed deep inside the space of radius, and in that way I can place the proximal border of the mesh under with the under surface of the rectus muscle. And now you can see the mesh is lying nice and flat over the right myopectineal orifice. The critical view of myopectineal orifice that has been created. And now the final step is closure of the peritoneal flap. So I have taken a 3-0 bob suture. This is an absorbable bob suture, and gradually will close the peritoneal folds in a continuous manner. So again, I don't use a tacker for my groin hernia cases, and usually prefer to do suturing. That will save some money, and also will give minimal post-operative discomfort, and the patient will be absolutely pain free and can be mobilized within 4 hours, and can be discharged the very next day. So that will make the procedure more cost effective and less painful. So better to do suturing. And if the mesh is sitting nicely, I generally don't do mesh fixation also, unless the mesh is the defect size is more than 3 centimeter, then I do 3-point fixation with suture. So gradually closing started from medial end and coming to the lateral end in a continuous manner, you can see. And so once I'm coming to the lateral end, what I did, I placed a needle from outside into the hernia bulge because of the pneumo creation that has been seen from outside the patient's groin, and that will let out the preperitoneal gas that is there after the closure of the peritoneal flap. And once I close this peritoneal flaps, the gas will automatically deflect the preperitoneal from the preperitoneal space, and the peritoneum will go and fix with the mesh nicely. So this is the final 1 or 2 bites that will fix the mesh, and now you can see the space is automatically getting deflated, and the peritoneum is getting opposed with the mesh, the polypropylene mesh that I placed. And mesh is lying nice and flat. Just to confirm, after going inside, this is the final picture of the mesh after placing inside. And the mesh can be seen nice, and these are the port positions from outside. And this is the final look, and under vision the pneumo has been deflated. Thank you for watching the video.